Hello everyone, welcome to our module on skin and soft tissue infections. In this video, we move on to one of the most practical and image-based areas of dermatology. This topic is extremely high yield because most of the questions are often straightforward if you can recognize patterns. So you'll be shown an image and your job is to immediately identify the condition based on the appearance and the key features. So in this video, we focus less on memorization and more on visual recognition and other different kinds of associations. Before beginning with the video, I would like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for everyone. If you find it useful and wish to support its development, you can do so with the link that is on the screen and that's also pinned in the description. You can contribute to us with any of these payment methods. So skin infections exist on a spectrum. So on one end, we have superficial infections like impetigo, which affect only the top layer of the skin. Whereas on the other extreme, we have life-threatening conditions like necrotizing fasciitis, which destroy deeper tissues and require urgent surgical intervention. So we always need to think in terms of the depth. So is it superficial or it's deep or not. So, because that determines both the severity and the management. In exams, this is the key step, whether determining whether it's a superficial or a deep lesion. Most bacterial skin infections are caused by two organisms. The first is the Staphylococcus aureus, and the second one is the Streptococcus pyogenes. These two organisms account for the majority of cases, and many questions can be solved simply by recognizing which one is more likely. So localized pus-forming infections usually suggest possibility of Staphylococcus, whereas diffuse spreading infections usually suggest Streptococcus. So this distinction uh, will be repeatedly coming up. Impetigo is a superficial infection of the epidermis, which is most commonly seen in children. The hallmark feature is a honey-colored crust, as we can see in this image. This is one of the most classic visual clues in dermatology. So whenever you see honey-colored crust, you need to think about impetigo. These lesions are usually found around the nose and the mouth. Because the infection is superficial and it spreads easily, it is a highly contagious disease and infection. So if you see a child with golden colored lesions, which are crusted, tattoo around the face, we should immediately think of impetigo. Now let's compare two commonly confused conditions, cellulitis and erysipelas. Cellulitis involves the deeper layers of the dermis. Because of this, the borders are not well defined. The redness blends gradually into the surrounding skin, whereas erysipelas, on the other hand, affects the upper dermis and the superficial lymphatics. So it has sharply defined and raised edges. So the difference in depth directly explains the difference in the appearance. Deeper infection is usually related to diffuse borders, whereas superficial infection is usually related to sharp borders. So this is a very high yield comparison, and this is also commonly tested on USMLE. Necrotizing fasciitis is a rapidly progressive infection that affects the fascia, which is the connective tissue that's surrounding the muscle. The most important clinical clue is pain that is more severe and out of proportion than we would expect based on the physical findings. This pain of out of proportion is also a red flag sign in cases of necrotizing fasciitis. As the infection progresses, gas-producing organisms or bacteria can lead to crepitus, which is a cracking sensation under the skin, and this is a surgical emergency, and early recognition is definitely critical. This condition is caused by a combination of bacteria or by group A streptococcus. The infection spreads quickly, leading to tissue death and systemic infection. If left untreated, it can result in sepsis and death. So the key takeaway here is rapid progression plus severe pain. This could lead to necrotizing fasciitis. Erysipelas or gangrenous skin, blisters or bullae, necrotizing fascia and muscle, presenting with crepitus on clinical examination, and also pus and swelling are the different clinical features of necrotizing fasciitis. Staphylococcal scalded skin syndrome, also abbreviated as SS. So this condition is caused by toxins that are produced by Staphylococcus aureus. These toxins specifically target a protein called desmoglein 1, which is responsible for holding the cells together. So when this protein is disrupted, the superficial layers of the skin separate, leading to widespread redness and peeling. Because the damage is superficial, mucous membranes are not involved. So this is a key distinction in between staphylococcal scalded skin syndrome and other disorders, other similar disorders like TEN or toxic epidermal necrolysis. Now let's try to compare this staphylococcal scalded skin syndrome with toxic epidermal necrolysis. In toxic epidermal necrolysis, the damage occurs much deeper that at the junction of the epidermis and the dermis. As a result, the mucous membranes are involved. So the key difference is between both these conditions is that superficial damage with no mucosal involvement, such as staphylococcal scalded skin syndrome, whereas deeper damage with mucosal involvement, such as toxic epidermal necrolysis. This distinction is frequently tested. Now let's try to quickly summarize this bacterial infections. Impetigo gives honey-colored crusted lesions. Cellulitis gives diffuse redness with ill-defined borders. Erysipelas gives you sharply defined raised edges. Necrotizing fasciitis gives you severe pain and rapid progression, and this is a surgical emergency. Staphylococcal scalded skin syndrome is toxin mediated and affects superficial skin layers. So, if you can visualize these patterns, you can answer most of the questions in just seconds. Leprosy is a chronic infection that is caused by Mycobacterium leprae. What makes this disease unique is that it exists on a spectrum, and the exact presentation on how strong the patient's immune response is. So instead of memorizing uh, the diseases, we need to think this disease as that with extremities on two sides. So, in this form of tuberculoid leprosy, the immune system is strong. As a result, infection is well contained. So, you only see a few skin lesions and they are well defined. Nerve involvement occurs early, leading to loss of sensory innervation. So, strong immunity results in limited disease, that is tuberculoid leprosy. Lepromatous leprosy. So in this form, the immune response is weak. The bacteria multiply freely, leading to a widespread disease. So you see multiple lesions that are symmetrically distributed, and nerve involvement occurs later in the disease. So weak immunity results in extensive disease that presents as lepromatous leprosy. So now let's just try to differentiate between tuberculoid leprosy and lepromatous leprosy. So this is a classic comparison that we all need to know, that we all need to know. So tuberculoid leprosy, there's strong immunity with few bacteria and localized disease. Whereas lepromatous leprosy is that's presenting in patients with weak immunity. There are many bacteria present and there is a widespread disease. So if you remember this contrast, you can definitely answer most of the questions differentiating this tuberculoid leprosy and lepromatous leprosy. Treatment involves a combination of drugs like rifampicin, dapsone, and clofazimine. The duration depends on the type of the disease. It's shorter for limited diseases and longer for widespread disease. So, bacillary or tuberculoid leprosy, we get treatment for 6 months, whereas for multibacillary or lepromatous leprosy, we get treatment for 12 months. So, the treatment is usually divided into uh, monitored monthly dose along with a unmonitored daily dose. So, a monitored monthly dose is included as a part of the regimen, as a part of the protocol, because to prevent antimicrobial resistance in case the patients are non-compliant to treatment. Lepra reactions are acute inflammatory episodes. Type 1 reaction is due to changes in the cell-mediated immunity. So this causes inflammation in the existing lesions and is treated with steroids. Whereas type 2 reactions involve immune complexes and presence with painful nodules and systemic symptoms. So again, cell-mediated immunity presents with type 1 lepra reaction, whereas immune complex mediated presents with type 2 lepra reactions. Warts are caused by human papilloma virus, so they lead to thickened skin with characteristic changes in the infected cells. These are very common and are easily recognizable. On histology, we can see the characteristic hyperkeratosis and chyliocytosis. Molluscum contagiosum presents as dome-shaped lesions with central depression. So the central indentation is the key identifying feature, as you can see in this image. So there's an umbilicated papule with a central indentation. Scabies is caused by a mite. So the key symptom in scabies is intense itching, especially at night. And these mites can create burrows in the skin, especially between fingers and toes. So this pattern is very characteristic, and scabies is caused due to a protozoan called Sarcops scabiei. Pediculosis is due to lice infestation, so transmission depends upon the type, but the treatment is straightforward with topical or oral agents like permethrin and ivermectin. So warts, molluscum, scabies, and lice all have very distinct visual patterns. So HPV presents with warts, poxvirus presents with molluscum, the characteristic umbilicated pattern as we have discussed earlier. And scabies presents with burrows between fingers and toes, whereas lice leads to infestation. Fungal infections are diagnosed using potassium hydroxide preparation. So this allows visualization of fungal structures under a microscope, and the characteristic finding is branching septate hyphae. Tinea versicolor is a condition that's caused by yeast that interferes with pigment production. So Malassezia species interferes with pigment production, and this leads to light or dark patches on skin, as you can see in the image. The classic microscopic appearance resembles spaghetti and meatballs appearance on KOH mount. So these dermatophyte infections are named based on the location. So what the underlying mechanism is the same. So if it's on the scalp, we call it tinea carpus. If it's on the body, we call it capitis cruris. Sorry, carpus. If it's between the burrows, or what we call as the fingers or toes, we can call it as tinea cruris. And if it's on the sole or food, we call it tinea pedis. This entire topic is totally related to pattern recognition. So let's try to quickly summarize the key findings from this module. So honey-colored crust is seen in impetigo. Severe pain is a surgical emergency along with crepitus. When it's present, we need to think about necrotizing fasciitis. Uh, then Leprosy, there are two types, tuberculoid leprosy and lepromatous leprosy. We need to understand the characteristic differentiation between both of them. One is related to strong immunity and the other one is related to weak immunity. One is paucibacillary and the other one is multibacillary. Scabies leads to nocturnal itching and formation of burrows between fingers and toes. Molluscum presents with characteristic umbilicated papules, and tinea, we can diagnose it using KOH mounts. So if we recognize these patterns, we can definitely score very well. I'll be right back with a video or the fifth video of our dermatology series. Till then, bye.